Introduction. Canine peripheral nerve sheath tumors, or PNSTs, have been extensively discussed in veterinary literature, recognized as slowly developing, locally aggressive neoplasms, mirroring malignant PNSTs in humans. The nerve roots contributing to the brachial plexus, specifically C6 through T2, are most commonly affected by these tumors. Among these, the 8th cervical nerve root, or C8, has the highest prevalence. These tumors are believed to grow along nerves in either a proximal, distal, or both directions, but rarely breach the epineurium. When PNSTs extend into the spinal canal, they can lead to compression or, less often, invasion of the spinal cord. Diagnosing these tumors can be challenging, as they often cause nonspecific clinical signs. Surgical excision of spinal PNSTs has been shown to be superior to conservative medical management, especially when an extramedullary neoplasia is suspected. Depending on the degree of preoperative limb function, location and extent of the tumor, and presence of other conditions, treatment options include local resection, forequarter amputation, hemilaminectomy, or a combination of forequarter amputation and hemilaminectomy, known as FAHL. A more favorable prognosis has been reported for PNSTs located distally to the brachial plexus. However, in previous studies, the distal extent of the tumor into the brachial plexus in cases with intradural extramedullary PNSTs, treated with local resection and/or hemilaminectomy or laminectomy, is not clearly stated. Unfortunately, tumor recurrence within a year of surgery has been reported in the majority of dogs, that is, over 85% of cases. Delayed diagnosis, increased postoperative morbidity after spinal surgery, and high recurrence rates render the prognosis for brachial plexus PNSTs invading the vertebral canal guarded to poor. This retrospective case series study aimed to describe the FAHL technique and report the outcome of 9 dogs with intradural extramedullary PNSTs arising from the brachial plexus that were treated with FAHL. Materials and methods. The medical records of dogs that underwent surgical treatment for a PNST at Aura Veterinary between January 2014 and January 2023 were reviewed retrospectively. Dogs included in the study showed clinical and magnetic resonance imaging, or MRI, evidence of a brachial plexus PNST, had no distant metastatic disease, and underwent a forequarter amputation combined with an ipsilateral hemilaminectomy as a single-stage surgical procedure. The researchers gathered recorded information regarding preoperative neurological and orthopedic examinations from the medical records. The dog owners were informed of the risks of this procedure, and the lack of extensive evidence for it. Their informed consent was obtained prior to surgery. Perioperative analgesia and anesthesia regimens varied among individuals, according to preferences of the referring veterinarian and the attending anesthetist. Preoperative MRI images were evaluated retrospectively and blindly by a board-certified radiologist who identified and documented the MRI characteristics of the lesions, the affected nerve roots, and their extension proximally into the vertebral canal in relation to the dura mater and the medulla, and distally in the brachial plexus. The surgical procedure involved positioning the dogs in lateral recumbency with the affected side up. A forequarter amputation was performed, as described by Seguin in 2018, transecting the muscular envelope encompassing the scapula and securing it to the body trunk. The loose subscapular fat and surrounding fascia were dissected gently to expose and dissect the brachial plexus. The axillary artery and vein were isolated, double ligated, and transected. At this point, the forelimb remained attached to the trunk only by the brachial plexus. The brachial plexus spinal nerves were then dissected towards their course between apaxial muscles so they could be identified by the intervertebral foramen they emerged from. All brachial plexus nerves and their corresponding roots were palpated to determine the boundaries of the tumor, which typically appeared as circumscribed or diffuse swellings of the affected nerve, firmer than normal nerve roots on palpation. The roots of all grossly normal nerves were followed proximally to their point of emergence from the apaxial muscles and transected as proximally as possible, without additional dissection. Lidocaine was administered around and into each nerve to be cut. Macroscopically abnormal nerves were dissected proximally until 2 to 3 centimeters of macroscopically normal nerves were exposed, whenever possible. If the tumor extended too close to the intervertebral foramen, it was either cut as close as possible to the foramen, or approached through a hemilaminectomy. To approach the nerve root or roots from inside the vertebral canal, The apaxial muscles were elevated from their bone attachments on the transverse and articular processes of the cervical vertebrae, and reflected. A hemilaminectomy was performed at the level of the affected nerve root or roots, and extended to several intervertebral spaces if more than one root was involved. A proximal ostectomy of the first rib could be performed to improve access to the T1-T2 intervertebral foramen, at the surgeon's preference. The affected nerve root was identified inside the vertebral canal, elevated gently with a vessel loop. A durotomy was carried out, allowing visualization of the nerve rootlets, and extended to form an elliptical durectomy centered around the insertion of the nerve root. The dorsal and ventral nerve rootlets were cut as flush to the spinal cord as possible. Normal rootlets appeared thin and almost transparent, whereas affected rootlets appeared thicker, opaque, and often mass-like. The access to the rootlets on the spinal cord was straightforward for dorsal rootlets, but required more traction for ventral rootlets, so if ventral rootlets appeared unaffected, they were severed as close as possible to the spinal cord without applying excessive traction. These steps were repeated for each affected nerve root. At this point, the forelimb remained attached only by the affected nerve roots. Progressive traction was applied on the affected nerve roots from outside the vertebral canal, and the nerves were dissected further proximally towards their intervertebral foramen. Care was taken to avoid rupturing the tumor. The tethers of the nerve root or roots to their intervertebral foramen could be felt to progressively rupture, until the nerve roots could be pulled out, and block with the rest of the brachial plexus and the forequarter. This often caused moderate bleeding, which was managed with pressure or an absorbable collagen fleece. The surgical wound was rinsed and closed with a wound soaker catheter. The proximal ends of the affected nerve roots were inked, and the portion of the forequarter distally to the tumor was removed. The remaining piece of excision was fixed in formalin and sent for histopathological diagnosis. Multimodal analgesia was provided postoperatively, and dogs remained hospitalized until they were ambulatory and comfortable on oral analgesia. Room confinement and controlled lead walks were recommended, and physiotherapy and hydrotherapy were recommended until full recovery. Patients were followed up 2 to 3 weeks after discharge, and if needed, primary veterinarians or owners were contacted for information. Due to the small population size and non-normal distribution of survival times, descriptive statistics, specifically the median survival time and range, were used to summarize the data. Results: 9 dogs met the inclusion criteria for the study. In 8 of 9 cases, the most proximal tumor margins on preoperative MRI images were more distant from the spinal cord than observed at surgery. That is, the tumors extended to the subarachnoid space at surgery, even though they did not appear to extend beyond the intervertebral foramen on MRI. In 6 of 9 cases, the tumor extended distally to the brachial plexus. In 7 of 9 cases, the 8th cervical nerve root, C8, was infiltrated by the tumor. The diagnosis of PNST was confirmed histologically in all cases. 3 PNSTs were classified as low grade, 5 as intermediate grade, and 1 as high grade. Surgical margins were clear in 5 cases and incomplete in 4 cases, where microscopic spinal cord invasion was suspected. 2 of the 4 cases with suspected incomplete tumor resection were later euthanized due to suspected tumor recurrence. 5 dogs were ambulatory within 3 days of surgery. 3 dogs could walk without assistance 9, 12, and 18 days after surgery, respectively, and 1 dog needed 28 days to walk without assistance, and developed postoperative hind limb paresis, proprioception deficits, and Horner's syndrome. All dogs were followed up until death, except for 1 case that was still alive at the end of the study period. Table 1 summarizes the signalment, clinical, and imaging findings of the 9 dogs in the study. This table includes the age, sex, breed, and weight of each dog, along with the clinical signs they presented. The location and affected nerve roots are also documented. For example, 1 dog, a 7-year-old female neutered Labrador weighing 22.6 kilograms, presented with left thoracic limb lameness and absent panniculus, with the tumor affecting the C8 nerve root. Figure 1 is an intraoperative view of a dog in lateral recumbency, showing a forequarter amputation with the brachial plexus still intact. The brachial plexus is indicated by an arrow, which is the only attachment of the limb to the trunk. Figure 2 also shows an intraoperative view where all the muscles between the trunk and the operated limb are cut, and the axillary artery and vein have been ligated and transected. The limb remains attached only by the nerves of the brachial plexus, and the tumor is visually identified and palpated. Figure 3 is an intraoperative view of the exposed cervical vertebrae, showing the site of the cervical hemilaminectomy. Figure 4 displays an intraoperative view showing the palpation of all nerve roots to estimate the tumor extension. Roots where sufficient margins can be achieved are cut outside the vertebral canal, while roots with tumor extension into the foramen are left intact. Figure 5 is an intraoperative view of a hemilaminectomy performed on one or several spaces to expose the portion of the affected nerve roots previously left intact. Figure 6 shows the dura mater of the spinal cord exposed after hemilaminectomies, and the affected nerve root is encircled by a vessel loop inside the spinal canal, highlighting the intradural portion of the tumor. Figure 7 is an intraoperative view following hemilaminectomy and durotomy where the spinal cord is exposed. A vessel loop is placed around the affected nerve root, and the proximal tumor extension is differentiated from the non-affected portion of the rootlets. Table 2 details peri- and postoperative clinical information for each of the 9 dogs. This table includes the time to ambulation after surgery, the survival time, whether tumor recurrence was suspected, the status of surgical margins, tumor grade, and follow-up notes. Discussion. A final diagnosis of PNST was only established postoperatively in all cases via pathological examination. Achieving a preoperative diagnosis would necessitate either cytology, which isn't always diagnostic, or histopathology, which is invasive. The inherent risks of misdiagnosis were discussed with the families, who elected for a single curative intent procedure. Consistent with the biological behavior of PNSTs, none of the cases showed signs of metastatic disease. The authors note that because 95% of the efferent axons of the radial nerve arise from C7-T1, with 45% specifically from C8, dogs with PNSTs affecting C8 are not considered good candidates for limb sparing. In other studies, cases with PNSTs affecting C7-T1 had a poor outcome with limb sparing. Limb sparing might be considered for isolated involvement of C7 or T1 that still preserve good preoperative limb function, but this was not the case in any of the dogs in this study. PNSTs have a low metastatic rate, so a cure can often be achieved by complete resection, which relies on seeking wide margins of excision. Performing a directomy for PNSTs invading the vertebral canal increases the chances of achieving full resection. The direct visualization of the tumor boundaries allows for wider excision margins as the rootlets can be cut flush with the spinal cord, rather than the whole nerve root flush with the dura mater. The tumor can also be removed en bloc with the leg, which avoids breaching the tumor compartment and minimizes the risk of tumor seeding. Most dogs deteriorated to some degree after the procedure due to the surgical manipulation of the spinal cord. However, all dogs in the study regained full unassisted ambulation within a month, with only 3 out of 9 cases requiring assistance for walks beyond 10 days postoperatively. Brachial plexus PNST local recurrence has been documented in cases with clear surgical margins. Thus, FAHL is a sensible option for treatment of dogs with intradural, extramedullary PNSTs of the brachial plexus, particularly when the C8 nerve root is affected. From Vet Neurojar, keep those minds inspired, hearts light, and tails wagging.